All right, I want to take you back now to the Eastern Cape. As we know, the Eastern Cape is very much in sharp focus. Over 65,000 cumulative cases have been recorded in that province. Over 800 fatalities. 44,000 people have recovered so far. Over 44,000 people. The Premier is currently holding a media briefing to give us the very latest. Let's listen in.
So the Department of Health, it's bankrupt. My question is that true? Is that the case, that the Department of Health is bankrupt? And now we've got this case of shortage of oxygen, which is very crucial at this stage.
Okay. Can we please get responses to these, and then we'll go to the Twitter questions that are sent through WhatsApp. Can we start with the SG of the Department of Health, Dr. Mbengashe, to talk to issues that are specific to the department? If you can please come to the podium, sir. And then we'll ask the MEC of Education to talk to issues specific to teaching and learning. And then the Premier will wrap up, and then we'll take the questions from colleagues that are not here. Thank you.
And this? Am I allowed to take this one? I speak through the...
They might dig between the two of us.
Okay.
You know best.
No. Thanks for the questions. Premier, let me start with the last question about whether the Department of Health is bankrupt. I'm going to answer this question in two ways. First, the department is not bankrupt. Basically, what happens is that the Department of Health has got 26 billion rand, which is the appropriation to do its ordinary business. And that's really managing all the critical work of the department, like the million people that we see on a daily basis in the primary health care, to cover over the 450,000 people who sleep in our hospitals, and to manage the 44,000 workers that are in the hospitals, and to make sure that all the 1,000 facilities are functioning. Now, obviously, the COVID was never really intended, and therefore it puts a very high level of a burden in terms of the budget of the department. That is also kind of compounded by the other costs that were related to medical legal. So what the government has done, it has appropriated another 2.6 billion rand just to fight the COVID and to provide the resources that are required to respond to the COVID. Is this money sufficient, and is it enough? My sense it's not, and I think when we made our estimates, we found that for really to have all the things that we need to have, to provide the number of human resources required, to provide all the beds such that even if the surge comes, we've got all those. We needed about 4.1 billion. But that does not stop us to actually provide the sufficient care services. So I think the key issue is that certainly the level of the surge and the demand of the resources and ability of us to meet those surge is way beyond any other government, including the Department of Health. But I think what I'm saying is there's been sufficient provision that will make the difference. How are we coping? I think the way we are coping on this is that there's a lot of injection from the other departments. Actually, many of the contributions that we made as to have more money has to move to other departments to support the Department of Health. And that has been a major contribution. Two, that there is a lot of resources from private providers, including the Solidarity Fund, the National Department, to complement the resources that we have. And that actually is creating a lot of ability for us to do way beyond what we would have done with our own money. So that's really the one question that was actually asked. Now, the second question is really about the facilities the facilities that we needed to provide. And the key issue really onto this is according to quarantine sites. I think we needed to explain a little bit about the differences in the service provision. What's really important is that when you look in terms of how we're going to be going forward with the epidemic, there was a lot of projections in terms of the models, what is the likely impact of the epidemic looking forward. So the forecasts have said that July, August, and September are going to be our heaviest month. Actually, the true nature of the peak is around August. And what it actually meant that if you look right where we are now, we're just about 67,000 people who actually had the infection. And if you really take that, that's about 1% of the population of the Eastern Cape. Now that 67,000 people happened over a period of about 6 months. What the research says is that these numbers now, because of their huge numbers in the system and the community spread, they can change that mathematics. What you took for 6 months to get to 67, it is going to take us 6 weeks to double that number to about 140,000. Now this is really the part that is really kind of frightening when we're dealing with the epidemic, is that the July-August month are actually going to make the numbers that we've been dealing with in the past 6 months having to deal them within 6 months. And that's really what creates the big challenge about the surge and our ability to respond to that. So how are we dealing with this? I think you will recall that when we started with the whole response was that we said we needed about 8,000 field hospitals. I'm going to spend a bit of time where they are now. We said we needed to repurpose around 2,000 hospitals, which is a COVID hospital. We said we need at least 300 ICU. That was based on the original projections on the models. The model said, look, when you hit the big burden of the COVID, you will probably be really needing about 10,000 beds to really respond to this. This is this last 6 weeks of the epidemic. And then it says on ICU you need about 3,000 ICU beds. And they actually projected then that if you don't have all the responses to actually deal with that, the death in the Eastern Cape will be quite substantial. I remember there was this number, about 6,000 deaths that were actually going around. Those numbers really were saying that if you don't really have a response that is adequate, that's really the end point that's going to happen. So what have we done? We have built the COVID beds in terms of responding to change the ordinary beds and re-engineer them and making bed. Currently, when we look into our system, by end of August, September and October, we should have over 3,300 of those beds. That's the first part. The second part is really the field hospitals. The field hospitals in PE, we plan to have about 4,000 beds. And in the districts, we plan to have about 500 beds in each one of those districts. That would have pushed our bed for field to really the 8,000. There are challenges into that, and I will really speak to that as well. On the ICU, we said we wanted to build the 300 ICU beds. We have reached those 300 ICU beds. But what really has made a huge difference as we're moving forward to this is really something that I really think it's important, because the science also made some difference. It made its own contribution in terms of how we deal with the epidemic. One of the science finding was that oxygen is a number one medicine for the COVID. And therefore, we needed to bring the oxygen in. And it also went further that if you bring oxygen in early, you are actually avoiding people to go to ventilators, which was the second part, which was very important. The third part of the science of oxygen was that you can actually reduce the stay by 4 days in a critical care just by having oxygen and actually providing people. So we have moved up now. That's what the Premier was reporting, that we are actually what is called, we're reticulating the facilities that were meant not to necessarily to have oxygen, to have oxygen. That changes the dynamics of our capabilities to deal with very sick people. The second part of the development was that the epidemic and the disease part was now better understood. That it really was not just one disease of an infection. It has 3 components onto it. And the way we respond to those 3 components are going to make the difference. The first 7 days of COVID is a viral infection, is the COVID. The second 7 days of COVID is actually not a viral that's really making a problem, it's the overreaction of the body, what is called cytokine storm. It's an overreaction of the immune system actually creating an internal destruction in itself. That problem now, we've been told that if we use a drug which is very cheap and accessible even to ourselves, the dexamethasone, we should be able to deal with the phase 2 of the COVID. That drug, in terms of what it does, it changes that most of those individuals, they would have gone to ventilations. They would not go to ventilation if we put the dexamethasone. Most of those individuals would have actually passed on. We reduced their passing on by 30% just by having those COVID. And the last one really that's actually coming up is that diabetes and heart problems are actually regarded now as more dangerous in a COVID person than the actual COVID itself. So our ability to manage diabetes, especially what is called metabolic problems, plus the hypertension is there. So the science from 6 months ago to now has changed. Our response is also flowing into that to respond into that. That actually means then there are new modalities available. We can change what was an ordinary ward to a high care ward and actually provide more care. The big challenge, of course, is really the rural small hospitals. The rural small hospitals, our strategy is that we're going to use the continuity of the canisters of oxygen and actually make those be available. And we are actually really feeling that one of the biggest areas that the Premier is saying that everywhere where patients comes in must have this oxygen early because it's the biggest component onto that. Now the next question was really about the PPE substandard PPE that was distributed. Yes, we did have reports onto that. What happened is that we have gowns on the PPE. Some of them are actually over gowns and others are overalls. Some of them are very light and some of them are quite thick, depending on the conditions where we were. So we had a problem, especially with doctors who really felt that the PPE, that the gowns that we're having are not good quality gowns. So the way we responded onto that, we moved those gowns to less risk areas and we're actually providing with the appropriate gowns. But the key issues on the prevention of infection is really the design of the system itself and actually using the infection control systems that is available. The last question which came up was really how do people, why is the province regarding itself more vulnerable than the other problem? There is what is called a vulnerability index, which is a really scientific an index that actually assesses the level of vulnerabilities. One of the big things about it is that vulnerabilities is a function of prior poverty and social determinant problems within a society. So if you've got a very high level of poverty, you are actually much more vulnerable. If you live in very high density areas like informal settlements, you are actually vulnerable. If you have households that have a number of people that are more than 5 or more, that creates a vulnerabilities. And if you really create a movement and mobility of individuals between areas, that's also created vulnerability. And the level of unemployment and all those things. So those vulnerability and the housing problems have created a problem. The province actually has shown that if you look at the high, the BCM, the Nelson Mandela, and those kind of areas where there's high number of people, there has been a very high infection rate. We also found that the lack of health facilities in terms of the qualities and access also created vulnerability. So those were really the vulnerabilities that we're dealing with. And I must admit that those vulnerabilities have created a huge pressure on the department and they really made it the success of the problem much more harder than it is, and they've really made a huge demand to all of us to really respond. And the issue about patients not receiving oxygen, I think the way we had that, and we went to Gray, and we actually investigated that problem, and it was really a sad story. And I listened to the voice part as well. I was really moved about that. The team went in to look at Gray and look exactly was there oxygen available. They have actually established that the oxygen tanks were actually available, and they were asking why was the letter coming up. What we think what happened was that when this oxygen mask fell on, there was a lot of fear from the staff who was actually working there to actually help her with the mask. But otherwise, the oxygen was available. It's something that we have not concluded in terms of. It's a very sad thing because we really believe that we're training our nurses very well. We're providing a lot of PPE. We need to provide a lot of psychosocial support so that no patient is actually left without attendance. Thanks, Brilliant.
Thanks, Program Director, Premier, colleagues that are presently here. I have just one question that have been asked by JJ around the contract we have on the e-learning program. One is that which we must first clarify is that probably we needed to resist JJ from politicizing supply chain processes, because we run a risk of litigating processes of government and render them quite a bit useless. When the debate arises at this particular contract for the first time, I wanted to take you back. It was about the compliance of the parties at play, and when that has been resolved, it becomes no issue. Because remember, the contract was about piggybacking on a contract between DDET and Sizwe IT company, and that one was resolved. And when that was resolved again, the issue was about whether the company does have capacity to roll out the e-learning program in the provincial space. And again, the very same member of DA, in particular in the legislature, we warned him that it can't be right that any company that has bidded for any transaction is in government, when it is black, it must be treated with suspicion. When it is white, then it is genuine. There is nothing to be suspicious about that. And that debate was closed. Again, the debate shifted and came into prices, the standard price in the market. The debate again came into whether are we able to make a comparison that is substantive enough on the basis that he himself has made a research about the items from Take a Lot company. Now the question is again, why do you subject government into faceless companies that have not prepared themselves to go to a bidding process in government? What are you trying to imply? Because they should have made themselves available in the supply chain processes of government so that they become cheaper there. It is not going to be correct and right that when we deal with the state capture internal in government, you bring it back via a back door. Because this statement is quite very pregnant in meaning. When somebody is not bidding in the processes of government, you come and represent him here and say he's cheap. Cheap compared to whom? Because the process of government, you only determine an expensive and a cheap contract via the supply chain processes. And that matter was closed. Now again, the issue is about 160 million versus 400 million. Mischievously again. The initial price that the HOD of the department, when he was presenting in the portfolio committee in education, was that we have got a twofold process of anytime, anywhere, anyhow e-learning program in the Department of Education. We have procured 72,000 SIM cards with a package of telescope centers, 13 of them in the province, that are going to assist in the process of capping a challenge that is going to be posed by the COVID-19 challenge, as lockdown has actually closed us in terms of level 5 at that particular moment in time. And therefore, we are not going to close the learning program on the basis that we are at level 5, but rather close institutions of learning, then redesign the schooling system in the province so that you are able to get the maximum attention and participation of learners and the outputs that you would want to achieve come the end of the year, whether COVID has taken us to January or February, by the way, so that you can be able to do that. It's quite an extensive package that does not just talk about SIM cards, that does not talk about just only 5G in terms of the data, that does not just talk about the tablets, that does not talk about the broadcasting of lessons and the facilities that are going to be needed at that space. That's what then the HOD explained in the portfolio committee. We then came back and come back and say, on the basis that we have procured 55,000 tablets for quintile 1, 2, and 3 for grade 12 in the province, and therefore included in that package, by the way, initially that we have. So that's how far we have been able to do. But however, we have also a serious cry of quintile 4 and 5, which also constitute public schools in the province. Now, meaning that we would have to service all grade 12s in the province that are coming from the vulnerable poor families as defined in terms of quintiles in education. That's how far we have gone. So the issue of 160 and 400 million is a comprehensive package within that contract, but phased in two different forms, that of quintile 1, 2, 3 SIM cards, and also broadcasting lessons that have been dealt with within that context. And again are the tablets that are 55 that we are, by the way, on the last district now in terms of distributing them. So it's quite a very tedious process, comprehensive contract that also involves distribution, training of the learners, and also including software within those devices so that learners can be able to use them to deal with the assignments, to deal with the programs across grades, across the subjects, and across anything that they would be required to do, even post the schooling period, afternoon or over the weekends. So we have designed it in such a way so that we can be able to deal with the challenge that I am just speaking about. So what I was trying to explain, JJ, is that the 160 was the initial one as based on the SIM cards and other related matters, which then later on includes the second phase of the tablets, 55 of them. Samsung should be Samsung, if I'm not mistaken, and then, if I'm not mistaken. But the issue which was raised was the issue of the price. And we clarified that, products of Samsung differs. And therefore it will be important that before they brought in this sensationalization and politicization of supply chain processes, they have researched it thoroughly. So that you don't here bring in an item of 3,000 rand against an item of 6,000 some odd. And then you feed the public. Because this narrative is quite very expensive to government to come and clarify itself on a matter that you know for a fact that you have got a contract and a detail in front of you, but you chose to create a narrative that is a bit a problem. Hence, I'm saying program director is going to be a problem, and I think I must raise it sharply here. It's going to be a problem that when government deals with anything that has got to do with state capture, corruption, and you bring it via a backdoor, either via oversight, using the levers of government, it's going to be a problem, and I think will be equal to that task. But however, the matter is before the court now. I don't know why this matter is not coming to the fore and be concluded, so that we don't feed the public by a narrative that is not there. They first take the matter to the court. They failed. They come back to the portfolio committee. They failed. Now they are using the media space. They are going to fail as well. Thank you, Professor.
Can you please answer this question? Let me see. The loaning of tablet devices to grade 12s at a cost of 400 million. If you've answered it, it would be fine.
Yes, it's the one that we are answering, Program Director. If you go back to that contract, you are going to get two clauses. The one is about the leasing of the devices using an agreement between the parties at play, and also the purchasing them directly. We were comparing two proposals. The other proposal was about buying them using another, I'm sorry to use names here, using another proposal that was done by Vodacom. Because we have got Vodacom at that space, which was a bit expensive for Department of Education. Hence, you then took a detour for a leasing via the ICT, CISWE, and MTN. But we can provide that detail if it is needed, Program Director.
JJ, sikhoqile phaya ingqondo uba ungawazi umahluko phakathi kwe-quarantine site ne-field hospital. Uyohlekisa ngaba bantu bangontlanganiso. Well, I think a lot of questions have been covered by answers. I think Asanda, what we are trying to say, we all know that there is no cure, there is no vaccine for this. It's just the immune system that is able to fight back and get our people over this virus. Those multivitamins and other things that our people are using, and some of them are prescribed by doctors, but some of them they hear from others. And siyayazi into okokuba apha kukho umhlonyana, and umhlonyane uyasetyenziswa, usetyenziswa nangaphambili kubantu abanomkhuhlane, and that umhlonyane has been working. And we are saying these indigenous kind of interventions are important for us not to turn a blind eye on. So that's the point that we're saying, so that we also probably disabuse ourselves of this over-dependency on the Eurocentric approach. On everything that comes, it must actually be coming from the West. And if it's coming from Africa, it's a suspect, it's not trustworthy, we've got all such kind of issues. So it's time that we are actually using our advanced research institutions, MRC, etc., to look at these and begin to probably give us answers. We might sit here, continue saying that there is no cure for this while people are recovering on the other side. So it's a kind of a contradiction that needs scientists to talk to. But we're looking for cure, we're looking for vaccine. That's what is actually understood globally. So that's the point that we're just trying to raise. The question, Kayanga, Department of Health is not under administration. We are assessing work that we are doing every day. As we assess work, we look on how do we calibrate our systems and improve our effectiveness to respond to challenges as they go. When we started at low. As we grow, now we are talking about peak, and we need to prepare ourselves for peak. So these are kind of issues that we're looking at. We would not be where we are. To date, we have almost screened in the province almost half of our population here. Almost 3 million people have been screened. Those people, that was not automated, was done by work out of strategy which was there in the Department of Health. We have actually tested people who are almost close to or above 250,000 as we speak. Those were manual tests. Those were done by our people. Contacts were traced by our tracing team. So we've been having a clear strategy what to do. We have not been clueless about the work that we've been doing on this. We know that's why we are where we are, and that's why we know our challenges. That's why we have been always proactive to say we are lacking there. We need assistance. We need support. We call for that assistance. We call for that support ourselves voluntarily. South Africa has got a unitary governance system. It's not a federal country. So when we deal with this, we deal with it in that context. Yes, provinces are allocated fiscals to work on them, etc. But we are having this cooperative governance arrangement, which at all material times must be able to help us to solve problems. If we have got challenges, we've got to work together to find panacea to any challenge that we have. So that's the relationship that we have. So national cannot sit national. National is us. National is any province. These teams are all over the country, all over provinces to help provinces. Every province now is surging. Every province is experiencing the surge. It's not a unique thing that is happening here. That's why this question, I would say, is very much mischievous. Actually, some people are just using the crisis we are in to play politics. Particularly those who are from DA calling for the Section 100 in the Eastern Cape. If you use the issue of COVID-19 as a barometer to arrive at that, why are they not calling for Section 100 in Western Cape? That has been there, up there, is now second, the largest. We're still following. We are working with Western Cape, myself and the Premier. We are comparing notes, we are exchanging notes, etc. So it's a pure mischievous call, which is just driven by political ambition, and it must be understood as such. Eastern Cape administration has got about 12 departments and 10 MECs, with Premier being the 11th one. So why would you call for the administration in the province? Because of health issues that we ourselves have detected, issues we ourselves have provided leadership. We are providing solutions to them. We are resolving them, working with national. So this is just a pure mischievous people who think that it's still a playtime, even at the peak of the COVID-19. We are watching them, we are looking at them, we know them, we see them, but it's a pure distraction so that we don't focus on the actual work at hand. And we're not going to be distracted. We are here on a campaign to save lives, and we are balancing that with the preservation of the livelihood. So we're very clear on our minds. The ANC government cannot fail on this issue. We've got to fight it right through and make it a point that we prevail on it. So these mischievous calls are just driven by such political ambitions from the people. That's why we are calling everyone. That's why we have got a platform where DA participate and others. It is only unique here in the Eastern Cape. It doesn't exist anywhere. That multi-stakeholder forum, we call it an extended provincial command council. It's working. We are meeting every Sunday where we take the reports. Everyone has got an opportunity to suggest, because our belief has been that we must work together to deal with this and to defeat this virus. We are not creating an opening political opportunities and for populist and political opportunism to think that it's time to do that. So we are not really much phased about that, but we are concerned that there are people at a point where we should all be having hands on the deck, but there are people who are busy trying to do other funny things that are absolutely not necessary. We have, I think that question would be linked to your question, Asanda, as well, on the systems, the dealing with symptoms, and as I've indicated, that the challenge that we've been having in this since the amalgamation of our provincial administration. We've got a unique situation which is really can't be easily found elsewhere. 3 administrations were brought together from 1994. We have been having these teething problems since then. There's been a challenge. That's why we talk about historical challenges and inheriting a huge backlog in terms of development. Our government since 1994 has tried its level best to address these problems. That's why we've built big hospitals over the period, your Cecilia Makwan, and number of hospitals that we've built across the province. We've built clinics, we've built community health care facilities, we've built big schools across this province. So that work, but we've been coming from a low base. So that's a challenge. It's work in progress. We're going to continue addressing those problems. So we need our people to support government that is elected by the people to ensure that we are able to deliver to what is our people are expecting. So this issue, it has been one of those issues that we subject ourselves to this very bombarding public attack. Remove this, don't remove that, remove this. We easily find scapegoats when we're supposed to be working together. Yes, where people are not working, there must be consequences. We can't just be stuck with people who are not responding to what is supposed to be responded. There must be consequences. On that one, we're very clear. But we should not be mischievous. We just always find a lazy way of doing things. Let's think deep. Ask ourselves where we are coming from, where we are going to. What has been the experience? We had Section 100 in the Department of Health in the past, just like in the Department of Education. They've been there.
All right, the Eastern Cape Premier, they're giving us a sense of what sort of challenges they're facing in the province, calling for all hands on deck. The key is we in the fight against COVID-19. He's also speaking about using some of our institutions to explore indigenous medication as well as treatment in the fight against COVID-19. But the message it's been always, since a couple of months now, is the 3 W's. Wear a mask, wash your hands, and watch your distance. But those 3 in itself are not complete prophylactics. They need to be used together as a layered response in terms of the tools that we have currently in the absence of a vaccine, the tools that we currently have at our disposal in order to stop the spread of COVID-19. So that was a sense from the Eastern Cape in terms of where they are in this fight.